All right. This first one is about screening lab and radiology panels for trauma patients. It says it in the title, low utility and are not cost effective. I love papers that give you the answer in the title. That way you don't have to read the paper. But every one of these papers that looks at this comes up with the same conclusion. This idea of doing these trauma panels where you're doing automatically, you do a chest x-ray and then you do a pelvis x-ray and then you do all of these blood tests and looking for, and then you do coagulation panel. Every study that looked at this basically says that's not a good use of resources and that you ought to do it on a more selective version. You know, when the ATLS first came out, you know, I don't think the surgeons, when they developed it, trusted the ER docs at all and said, here, just do all these tests because we don't have any faith in your judgment whatsoever, so do the whole thing and throw the net out there. But this basically is another typical paper, Huron Hospital review of 4,000 tests and in 410 patients. They looked at about $500,000 and basically concluded that selective testing would have saved this one hospital $1.5 million. Now, I don't know whether that's cost or charges, but all of them basically are the same. When they look at these studies that actually change what you do, very, very few of them really matter. And like even things that are routinely abnormal, like you do a trauma case and the potassium comes back 3.2 or something to that effect. Well, that's about adrenaline being circulated. And as soon as you fix a problem, the potassium will come back 3.8 kind of thing. So just because there's these abnormalities doesn't mean that you need to fix them. Anybody?
Yeah, I think everybody in the room probably agrees about this. One thing I wanted to point out is that 42%, sounds kind of bad, of the CBCs were abnormal. 42%. How many did it make any clinical difference? Well, they do a percentage, 0.3%. You know what that means? 2 patients. In 2 patients, they said, oh, geez, you know, the white count's high, or maybe the blood count's a little low, or the platelets or something. I mean, that's 2 out of 400.
And this is important because trauma is a disease of young, uninsured, drunk men, for the most part. People who are going to...
Hey, what am I?
Hey, wait a minute. He's insured, and he's not young.
I am drunk, though. Okay,
and,
right.
You know, so these are charges, you know, these are things that we can save money on patients that can't afford them. And trauma centers are closing, you know, left, right, and center. It's kind of a loser money business. So it's something to look at. You know, most people, they don't crash their motorcycle because they have a low sodium. It doesn't matter, you know, it's a waste of money.
Excess testosterone.
Yeah.
We need a testosterone extraction.
No, we can measure those levels, get a rapid enzyme.
So a couple of things. One, they measure an amylase. I mean, everybody knows it's the most worthless test in the world. And then they measure a CK. Well, what? If it's normal, that means you didn't get bruised? I don't know what they're looking for here. So the trouble with this is you say, well, let the inexperienced docs get a lot of extra tests just because they don't really know where to look for things. The trouble with that is that ignoring a positive can only be done by somebody who says, you know what? I know enough and I feel comfortable enough that I'm going to ignore that test. Most of us can't do that. Most of us, if we get an abnormal, we feel we've got to do the confirmatory testing. That's where the money is. The money, you know, an amylase and a CK, they don't cost all that much. But it's when you get the CK that's abnormal and you think they need a series of cardiac echoes to prove they don't have a cardiac contusion. Or you say, well, my God, the amylase is up. Let's also study their pancreas by getting another dedicated pancreatic CT. That's where the money is in this kind of stuff, because once you get the abnormal, it's very hard to ignore it in this.
All right, let's move ahead to number 2. Unless you've been dead these last, it's actually a year or 2, you probably know that CT... Is that working?
It's an advantage.
Maybe so. Is there a switch? That's better, I guess. I don't think there is. Anyway, so you're probably you probably realize the last couple of years we've become a lot more sensitive to the issue of radiation with CT scans. And where we never used to think about it, we now know, I'll just give the general things, you know, that about 1 in 2,000 abdominal or chest CTs leads to a fatal cancer, not just a cancer, but a fatal one. 3/4 of all the radiation the people in this room are getting are from CT scans. Probably 2% of all the cancers now are due to medically induced radiation, all kinds of bad things, and it's only getting worse. that you'd think that these new, faster scanners and all that would be better. They're actually worse. When you have a 64-slice scanner, you get more radiation than with the 16, more than with the 6. And on top of that, there are some countries that do even worse than us. Japan somehow scans its population 3 times as much per person as we do. They still live forever. I don't know why that is, but they do that.
It's the green tea.
That must be it. It's the antioxidants and the sushi. Anyway, this looked at the PAN scan, which is done, if you work in a trauma center, you know it's done a lot. And I kind of like this study a lot, you know, because it wasn't done in the sickest patients. They did it in the level 2 traumas, about 86 of them, you know, who are a little bit sick. They have scores up to about 14 ISS scores, stuff like that. And so you'd think that there's no excuse to really, you know, fry all of these people, but they did. Is kind of what they did. Average age, 32 years. They had a full trauma PAN scan in 79 of the patients. That's 92% of the patients. The median number performed of the scans was 3, and the range went up to 10. This is all in the first 24 hours. Median dose equivalents, you know, went from 3 up to 26. That's sieverts, millisieverts, which is a little like REMS and RADs, but that's what they use now. And the median number of plain X-rays was 10. One guy got 64 plain X-rays. That's nice.
Like 1 per bone.
Medium total radiation exposure was about 7.5. Anyway, everything is terrible about it. The median total effective dose delivered over 24 hours, ready for this? 40. That probably triples or quadruples your rate of having a fatal cancer. And that's in the first 24 hours. That's equivalent to 1,000 over 1,000 chest X-rays, or I guess you could say 250 chest X-rays and 3 obliques for each, I guess like that. And in that, you know, group alone would be another over 300 cases of cancer in 100,000 patients. Some patients got more than 10 CTs, more than 10. So anyway, I think it kind of speaks for themselves there. You know, it's about a 0.3% risk of a fatal cancer from doing these kinds of things.
Are any of you starting to talk to your patients about this risk? Like, it started this conversation, yeah? What do you do? How do you include that in your practice? You know, and there's also the concern over intellectual deficits in kids as well. You know, they did those studies with the hemangiomas where they radiate kids, and they showed that their cognitive abilities really decreased, I mean, pretty dramatically, and there's that risk as well, let alone the carcinogenesis, and that's a significant risk as well.
And breast cancer in women. My understanding is a single chest CT increases the chance of a breast cancer, not fatal, I admit, but still breast cancer, about 1 in 500.
And the same thing's actually been shown about, just now everybody's doing CTs of the neck because the lead shows you can pick up more fractures by doing that. So they're talking about thyroid cancer and breast cancer associated with those X-rays. You know, I can't think that, well, there are lawsuits, but not related to, you're going to get cancer 20 years from now. You'll never get blamed for it. You know, you're going to be dead by the time they get cancer. They won't be able to come after you. But there were certainly these lawsuits at Cedars-Sinai, where the machines were, giving.
Well, they deserve that.
The machines were miscalibrated or something to that effect, and all of these stroke patients who were getting CTs of their head were losing their hair, and they found out that the machines were grossly miscalibrated. I think that there's going to be a lot of lawsuits over that one.
There should be.
There are already.
But I haven't seen any, and it's not likely. I think this point that Jan made about this intellectual impairment is actually more of a compelling case than the cancer. The cancer is you're either going to get it or you're not. It's, 1 in 2,000 you're going to get it or you're not going to get it. The intellectual impairment issue is more of a sliding scale, and the idea of a parent pushing to have a CT of a kid's head and risking somewhat the intellectual performance of this child is I think, a much more dangerous and insidious kind of.
Well, correct me if I'm wrong, but wasn't that the Scandinavian stuff, or it wasn't CT scans? They were actually radiating thyroids. I mean, I don't think that's the same as...
No, they were rating hemangiomas of the
Hemangiomas
face.
too, but also the thyroid.
Right, and then they measured intellectual performance based on testing when they got out of high school and when they went into the military. Dose response, definite decrease, and the threshold level where it started to decrease was the level of 1 head CAT scan.
And so this obviously probably only refers to little kids, right. But especially since we know we don't have to do those CTs of the head, I think this adds a lot. If you speak to the mother and say, to tell you the truth, let me just tell you that, then if she says, I still want it, well, maybe she was one of those that got radiated. That's why, who knows?
Well, you won't have to worry about college.
Yeah.
You'll save yourself a lot of money.
What's interesting is that the radiologists want you to get a permit form for giving the
100%.
contrast, but not for giving the radiation.
They do now, actually. Those guys do, yeah.
Yeah. I'll let you know 2 weeks from now.
You got a case like that? Yeah. Well, no, it's obvious. Well, there's lots of, there's lots of times when you're sued for not getting it.
Right.
Okay.
All right, number 3 is about CTs in kids, and it's called this hospital admission and observation required after a normal abdominal CT scan in kids with blunt abdominal trauma. So basically they look at these kids, there's 1,000 kids here, who were scanned, abdominal CT scan after blunt trauma, it was normal, and then they're admitted for serial exams. And they want to look at these 1,000 kids and say, did we miss anything? If we would have just sent them home, would we have missed anything? And they found that they had a couple misses. The kids that had initially normal abdominal CT scans who were admitted for serial exams developed something. They had 2 misses. One was a kid who had an abdominal seatbelt sign on presentation, and we know that that's infamous mechanism for missing something, right? CT is no good for picking up hollow viscous injuries and mesenteric tears. We know that. And the other kid was a kid that had a traumatic brain injury, multiple pelvic fractures, and it turned out that her crypt dropped a couple days later after she got admitted, and so they CT'd her, and she had this perinephric hematoma that didn't even need to be operated on. And the first kid with the seatbelt sign got operated on, and nothing, they didn't have to repair anything. They just saw the injuries and let it go. So they had 2 misses there, but they basically were saying that the negative predictive value of a normal abdominal CT scan in these kids who had blunt trauma was very, very high, 99.8%, and really 100% for anything that needed to be intervened on. So it was a very predictive test. Now, when you read this, however, you would say to yourself, did they really need these CT scans in the first place? What about just observing them? Did we really need to be doing abdominal CT scans on all these kids that had a blunt mechanism? Shouldn't we maybe, again, pertaining back to number 2, some of these kids just watch them instead and see what goes on instead of scanning all these kids just to try to get them home faster? Comments?
I think that, maybe 10 years from now, we'll look back on these days of the CT scan and saying, I can't believe we did that, because there'll be MRI machines that are 7 Tesla MRI machines, which will basically replace all of this stuff. But we're obviously not there yet. Our hospital is real close to Caltech, and one of their students was jogging at night and tripped on a curve and knocked out a couple of teeth and hit her head, and she was a bit of a mess when she came in. But she turned out to be an operator of a 7 Tesla MRI machine at Caltech. So these things exist. And she said, I said, do you want me to do something now? I'll be happy to, She said, no, I'll do it at Caltech tomorrow, where she's taking, state-of-the-art machine and checking herself out.
She's going to MRI herself?
Yeah.
Right.
We're going to talk about CTs and EPIs. 2 of the lectures we're doing are going to talk about that. The case will be all of these people should have ultrasound first. This 2-step process would save a lot of them, and particularly in children. But nobody wants to do that.
You're talking in non-trauma.
Yeah, we're talking about appendicitis.
Well, what the man is saying is exactly right.
Right.
We've all seen that how many people I don't even call the surgeons. What's the point of calling them until you have the CT? That's their first sentence. And so naturally, these are residents I'm dealing with, of course they're not going to get skills in doing the exam because they actually don't do the exam.
Yeah, but we're aiding and abetting, because if you take that attitude, you'll never embarrass them to come down and see the patient before you're going to do it. And if you have enough status in your hospital to stick up to, especially residents for crying out loud.
To say what? To say come down and feel it? And they would come down and feel it and say, get the CT. Every time. They never come down and feel it and say, don't get the CT.
Come down and feel it. I've got the ultrasound.
See, I don't know.
If I could do that, then they don't have to call them. And I would do that.
See, I don't know where I am. I deal with staff surgeons, and if I call them and I say, I've got a kid here, clinically, great story for appendicitis, great exam for it, it's a male, and this and that, and 3/4 of them will just say, okay, I'll meet him in the OR, thanks, goodbye. And some will say, well, they'll try to find something atypical to justify a CT scan, but a lot of times they'll just say, okay, I'll do that. Now, if they'll say, well, I don't know, they're female and they get a lot of other stuff, maybe I'll do that, but I don't get that all the time. I think I've got guys who will...
You're lucky.
Yeah, I am. I know that.
I mean, I got one guy like that.
Yeah. They're worth their weight in gold.
The best surgeon in our hospital, basically, he's probably, 60 years old. He will clinically do these things. He doesn't... It's only the gray zone cases you're supposed to be talking about. So if it's obvious, he does it.
Number four. Number four, so the preamble to the previous study was saying, now the new generation scanners, they're so good that really if it's negative, we're done. This is a before and after study. They said, we used to have a 4-slice scanner. Now we have a 16-slice scanner. Are we any better at finding mesenteric and bowel injuries? And the answer is no, they're not. They missed a lot of them before, 20%. They missed a lot of them after, 20%. I don't think that has anything to do with the generation of the scanner. I think it's just that it's an insensitive study, no matter how good your scanner is, or the radiologists were never any good to begin with, so they didn't get any better with a better scanner. But I think that's the issue. The other thing was that they said if they missed the bowel or mesenteric injury because the scan was negative, their average day in the hospital was 35 days versus 14 days. See, I think that means either they were sicker or they really have no judgment. Like the next day when they've got peritoneal signs all over the place, they say, oh, well, but the CT was negative, it can't be bad. I don't know what that deal is, but again, before and after studies are a little bit hard, but they say the 16-slice scanner didn't save them. Of course, 16-slice is not a big scanner now.
Of course, it was 1 in 5 they missed, which means they got 4 out of 5. So it's not terrible, but I agree with everything you say there.
You remember these seatbelt signs, the bruising across the lower abdomen. It doesn't really matter how bad the bruising is. It can be not that bad or really bad. You don't really know. It's more that it's just a sign of a mechanism that puts you at risk for these things. And the only thing that we have right now is to really watch them, unless you're going to do a DPL or something like that. But otherwise, you have to serially examine these people, and if they get tender, then you got to go in. So it's just a mechanism to be concerned about.
Number 5 is a scary paper. It's about aortic injuries and associated with high-speed motor vehicle accidents. And they had these 4 trauma surgeons blindly review the plain chest x-rays of 45 people who were ultimately shown to have blunt thoracic aortic injuries. And they also reviewed 56 control patients who did not have aortic injuries. And the bottom line is that they missed 5 of the aortic injury cases when they looked at plain chest x-rays, in that they did not say this person should therefore have a CT because of suspicion. So they missed 5 of 45. On the 51 patients who had no aortic injury, they said 25 of those people needed to have a CT because they were suspicious of the findings in those cases. This paper therefore concludes that plain x-rays, read by 4 different surgeons, are not good at picking out the aortic from the non-aortic injuries in high-speed motor vehicle crashes. And they suggest, which is a bit of a, aggressive move here, that these people routinely have CT angiograms if you're a victim of a high-speed motor vehicle crash. Sounds like it's pretty aggressive, but they said plain X-rays don't screen well for this disorder, which is a life-threatening condition.
But what's a high-speed crash?
That's the issue. This is a very artificial study. that they don't ever know their mechanism of injury. They don't ever know what their exam is. Most surgeons or most people put all that together. They hit the bridge abutment at 100 miles an hour and fly out of the truck, that kind of thing, or not. And then this only says that the surgeons aren't good at reading the x-rays. It didn't say there weren't findings on those x-rays. They just said they wouldn't have proceeded to it. So this is a whole external validity issue. I think, does everybody else practice like these 4 surgeons do? This is, again, I've had my rule on a lot of these things. If you want to know if it's a good article, you can actually do a little bit of triage. If it's in the Journal of Trauma, pass it.
Plus, I think we've known this for a long time. Did anybody think the chest x-ray was 100% for this? For neither traumatic nor non-traumatic, is it 100%? So they missed 10%. I think that's what every book has always said, right? And you're supposed to suspect those most of the time, on other grounds. And who knows about this 10% of the 49? I believe that's 4 patients. Who knows how many of them even really got an operation, or did they just have a little flap there? And so maybe you'd be doing them a disservice with that. Hard to say. CT for traumatic aortic dissection has a 2 or 3% false positive rate, because of that thing at the root of the aorta. And I wonder if this wasn't that.
Yeah, and like you said, we all know that chest x-ray isn't perfect for this, but mechanism matters. And they don't really talk about what these patients were complaining of. Were they complaining of chest pain? If someone was in a terrible crash with lots of fractures and they're complaining of chest pain, I don't care what their chest x-ray looks like. I'm still going to go looking for something bad like this. It's a deceleration injury. I'm going to be worried about it sometimes. If the chest x-ray, it's not going to dissuade me if I'm clinically suspicious. And this paper is really not about that. It doesn't address that part of it.
And continuing on with the Journal of Trauma having titles and articles that actually have nothing to do with the title. This one's kind of a beauty here. It's number 6, imaging may delay transfer of rural trauma victims. Okay? Sounds like, okay, this has nothing actually to do with that. They didn't look at whether there was actually a delay at all. What they actually did is a survey. They sent it out to 218 physicians, and they got 70, a bunch of responses, 70%. And what they were asking is, before you send people to a trauma center, do you do imaging studies? Guess what? Most of them do. I know I do, that's for sure. But get this. 1/3 stated they obtain imaging studies in trauma patients prior to transfer based on misperceptions about the expectations of the receiving physician facility. I bet they didn't say that. I bet nobody responded saying, yes, this is what I do. I do it based on misperceptions. No, they didn't do that. What they did is they answered the question and said, yeah, I think they'd like a chest x-ray at the receiving hospital. If I call somebody up and say, gee, this guy just had a bad, trauma. He went into a bridge and his chest hurts. They might ask me how about getting an x-ray before you call a helicopter? Or maybe they'll say, as long as you're doing all that stuff, get the CT scan. We'll take them anyway. That's, of course, what they say. Does it seem pretty smart? Anyway, so they go through this whole thing. And they give some other answers. Half believe that the law specified a minimal evaluation that must be provided. Now, the law actually does specify that. They're saying that that's wrong. That was a misperception. No, there is a minimum evaluation that has to be provided. We all kind of know what that is, at least. They were probably wrong when they said that the law didn't allow you to transfer an unstable patient, because you can do that if you're going to a higher level of care. But at any rate, their final conclusion is that people are out there and care is being delayed, transfers being delayed, and those imaging studies are probably going to be done at the receiving center either. But there's actually, I don't think any data to really support this. I'm sure that there are times when things are delayed, but there's most of the time when nothing's delayed, when in fact you have to do that workup and get the transport team together anyway.
The other issue is, for a lot of places, I work in a place that has a transfer big-time stuff. If the study's negative, we can keep them. If all they did is break their femur, we can keep them. But if they've got a spleen and a liver and an aorta, we can't. So sometimes a negative study keeps them. So you're right. That's an
excellent point.
Right.
And by keeping those, you may be actually speeding up the overall transfer of people who need it.
Okay, number 7. The necessity to assess anticoagulation status in elderly injured patients. Another Journal of Trauma paper. This is from Alameda County or Highland in Oakland. Chart review, looking at the relationship between an elevated INR, meaning 1.5 or higher, and mortality in elderly trauma patients, 50 or older. Elderly. Elderly. That's the best part of the paper right there.
I've already said bad things about the Journal of Trauma, so don't get me going any more on this one.
Yeah. Basically, they look. This is not a very good paper, but they basically look at INRs and in these older patients.
Median age 67.
Yeah. And median age was 67. And they basically, the doctors ordered the INR when they wanted to, and they just sort of correlated, like, people who had elevated INRs, did they do worse? What was their mortality compared to those who didn't have elevated INRs? And in fact, they found that mortality rates in the patients with INRs below and above 1.5 were different. If you were below 1.5, your mortality rate 8.2%. If you were above, 22.6%. It was worse if you had a brain injury. What does that tell us? It doesn't really tell us very much. It tells us that, those are sicker patients to begin with, that they had their INR elevated, and so that's why they had higher mortality. Was it really the INR that made a difference? I mean, I guess part of the point here is that, perhaps older trauma patients who are sick, these are patients that you're not going to necessarily not do tests on, like we were talking about before. Trauma screening tests are not appropriate for everybody. There are some patients where you do want to do some tests, and if someone's going to have an elevated INR, that means it's a marker of other things. It doesn't necessarily mean that the elevated INR causes all their problems. It's just a marker. It's just part of the whole picture. I don't know that you can look with a microscope at that little part and make big conclusions, right? Yeah.
The implications are that if you could, although it doesn't say that, the idea is, well, if you have this abnormality, should you preemptively try to fix it by giving, fresh frozen plasma or any other thing that you want to use to try to fix an elevated INR? Is that the canary in the mine and fixing it, or is it a marker of these more broadly?
Yeah, but they don't look at that, do they? They don't answer that question. I mean, you're right. It's like that's the next question, but they don't. Who knows?
The reason that paper's in there is there's this growing papers in the literature about coagulation profiles and transfusion protocols in traumatized patients, and I think there's a little cluster of them right now.
Right.
So 8 is pretty much the same thing. So the first part in 7. First of all, these people that had the elevated INRs were older and sicker. They had, increased ISS, and they were older, that kind of stuff. You might figure that a bunch of them were probably on Coumadin. So, of course, they had some condition that caused them to have Coumadin. And because this is all physician judgment, just like the one in 8 was. This 8 was kind of a similar thing. They looked at inpatient mortality in people if they had abnormal coags. They did more than just the INR. They looked at platelets, they looked at PTT, all that kind of stuff. And they said, it was sort of dose-response kind of thing. The more abnormal your coags, the higher your mortality. And so, again, is it a marker? It's certainly a marker of brain injury. You shake your brain around hard enough, and how you used to do coagulation tests to get the blood to defibrinate was to put rabbit brain in it. That was the old way of doing it. All the lipids in brain caused the coagulation cascade to go. So, is this a marker for brain injury? Is it a marker for generalized systemic injury? It may be. This test isn't going to prove it, but I think it's the point that Rick made is, do we take then the leap of faith that says that if this is an abnormality and the mortality is higher with it, should we fix that abnormality? That's another set of issues that none of these are going to answer for us, and we need to be real careful about that part.
These two papers, 7 and 8, is this just all comers over a certain age, and they just measured the INR?
No.
Did they separate out the patients in Coumadin, or what?
They just said physician judgment.
Right.
Now, the physician, if I were the physician and they said, I'm on Coumadin, I'd say my physician judgment is check your INR. So these people had some reason that the physician wanted to check it, and they didn't even say about that.
Well, isn't that part of the trauma panel?
Yeah. My guess is that those two institutions, probably almost everybody got an INR, because they all got an amylase too, So it wasn't too selective like that. But it's just like if you did a PSA on everybody.
Well, I don't know. In the first one, 1,200 out of 3,200 people got it, so it was not even half.
Well, if somebody comes in and they have a possible brain injury, on Coumadin, I'm going to CAT scan it. Right. I don't care what age they are. Right. The thing is that I still can't make sense of these papers. Like you told me that just by happenstance,
Well, it's not
not
no reason at
necessarily.
all. It is brain injury, and systemic injury starts the coagulation cascade.
Yeah, I mean, it doesn't have to be just brain injury. Brain is particularly good at starting the cascade and DIC, but other soft tissue trauma, if that juice gets into your bloodstream, it does also act in a similar degree, but maybe not as aggressively as brain tissue does. There was this study of people who had brain hemorrhages, strokes, where they gave them factor 7A to say, well, we're going to stop this stroke, this hemorrhage, we're going to make it smaller by giving this factor 7A to these people who had coagulopathies and had a bleed in their head. And yes, it made it smaller, but its outcomes were the same. Just as many of them died. So the idea of trying to fix the problem, yes, you got an intermediate marker that was good. The hemorrhage was smaller. Outcomes were the same. So that study with factor 7A and coumadin bleeding in the head, that got stopped. Number 9 is kind of like a little bit of expansion on this now. So they're looking at an Army study where the people got these massive transfusions over, 10, it's more than 10 units over 24 hours. But in ER, we're really concerned about, what's happening in the way of transfusions over 3 or 4 hours. But in any case, they tried to look at the ratio of platelets to pack cells that were given and outcomes. And so they divided the platelets to, basically you got 1 unit of platelets for every unit of red cells, to the other extreme where you basically got lots of pack cells but virtually no platelets. And they then correlated this with outcomes. Exsanguination as the cause of death was most likely in those people who got the worst ratio of platelets to red cells, and it was best in those who got almost 1-to-1 red cells to pack cells, as was median time to death and 24-hour survival. So this is another one of those where there's an association here. Maybe they try to say that patients had similar levels of injury through the injury severity scores and those kinds of things. But there's a growing trend that suggests that what we should be doing in these massively transfused cases is reconstitute whole blood. In essence, gives one unit of platelets for every 1 unit of packed cells. And is that not what you're doing?
No, it's not what we're doing.
Why not?
Well, it's probably more for practical reasons. I mean, how often do you know that somebody's going to be massively transfused, that you're going to need the 10 units or more in the 24 hours? I mean, A, that's not that common of a patient. B, it's hard to have that crystal ball and know that that's going to happen. We don't have a protocol for that. Part of it is because our blood bank, we've had this discussion with our blood bank. We've actually had a recent grand rounds on this. Our blood bank director doesn't believe in these papers. He believes that these are not methodologically sound, blah, blah, blah. We've had a lot of arguments about it. So that's one of the primary reasons. But there are hospitals, I know Stanford has a protocol where they have, if you see this patient going down that kind of path, we send you the box. The massive transfusion box that has all these things packed in it. They got the platelets, they got the FFP, all the stuff that you need to keep it, 1-to-1, and with the hope that it's going to increase your survival because you have more real reconstituted blood. You're losing, you're not just losing the red stuff, you're losing all of it, and so let's put it all back, kind of thing.
Well, I hope you're not arguing, that these are methodologically good papers.
No.
The fact is there's no prospective study that, this would be a crazy thing to start doing on a large scale. I mean, think about that without showing that you've saved a single life. I mean, they do it. They do it in Iraq and Afghanistan. And if you're ever going to do it, you're going to do it for a young soldier, They don't care about the money or anything.
Right.
And that's fine. But let's do the study. That's what number 1. The next one, number 10.
How are you going to do a study on a massively transfused?
You're going to do it in the military.
Double-blind?
That's exactly
Right.
how you're going to do it.
And those are a certain
Look at number
population of
10.
people. Those are young people.
No, absolutely.
Right?
It's perfectly doable. This is how military medicine is advanced because you can have, these are all penetrating injuries, not all, but 80 or 90% of penetrating injuries in war zones, for example. And you look at the next 100 patients that you transfuse in the usual way, and then the next one that you transfuse in a different way. That's how you do it. This article number 10 pretends to do that. It calls itself, this got rejected, I'm sure, from the Journal of Trauma, which is, not that great. And it pretends that it's a prospective study. It uses the word. This is a prospective study of over 800 patients, 806 trauma patients. And when you read the next sentence or two, there's nothing prospective about it. All they did is they looked back and they saw, well, how about those people that got the 1-to-1? How about those people that got the aggressive fresh frozen plasma early on? How did they do compared to the other ones? And the long and short of this whole paper is that you can't say from this, they could find no difference at all. They couldn't find a difference in number of ICU days and certainly not mortality. They just couldn't find anything. Then they did logistic regression analysis, which, of course, you only do in a retrospective study, to look back to say maybe there is something that will come out, that would identify it. Maybe young patients would do better with this, or older nothing. Nothing at all came out. So, it's not much of an article, but there's sure no support for, making a huge and expensive change in policy.
Any of you have these these transfusion boxes in your trauma centers? What's in your box?
It's a multi-step process depending on how you anticipate transfusion, and it involves our pathologist, the specific pathologist in your transfusion committee who actually wears deeper, depending on how the trauma is going and their anticipated need for blood, it will stepwise work up to whether they're just doing FFP versus the other components, and the pathologist gets involved in doing that and measuring it. It worked out very well for trauma service, and it was initially started with the cardiovascular surgeon because they were using more blood than anybody else. He started the process with them, and then it moved on to the trauma service, and it works really well, but it works well simply because he's the driving force behind it, and he knows the process much better than any of the surgeons or anybody else.
So remember in these studies, the military studies, these are not only penetrating trauma, this is massive penetrating trauma. This is the patient's body is shredded by these IEDs. In a course a couple of years ago, a guy had just come back from Iraq. He says the average transfusion requirement for these IED patients is 100 units of blood. So it's easy to predict who's going to need more than 10 units of blood when both their legs are blown off and their body is shredded with shrapnel. And it's a different injury mechanism. Remember when we talked about hypotensive resuscitation? They took people and they said, you know what? Don't get their blood pressure up very much because you've got a hole in an artery. So if the blood pressure in that artery is less of the blood squirts out. But that's not the mechanism of death in blunt trauma. Mechanism of death in military trauma is almost always exsanguination. They bleed to death. That's why they die. It's not because their pancreas is pulped up. It's not because their head injury, other than penetrating head injury. So this is a different mechanism of injury. I think before we want to translate something where you're making holes in blood vessels and saying, let's just plug up that with good blood, let's do a study in blunt trauma. And as Mike said, the only blunt trauma patients that have been studied, that hasn't worked out in. It hasn't worked out for hypotensive resuscitation either. But you would anticipate that would be a great thing in a blunt trauma or a ruptured aortic aneurysm or something like that. Just keep the blood pressure down until you can definitively control the hemorrhage. So I worry, though, that this is about as good as these studies are going to get. How do you control for the degree of severity of injury with these IED things? That one leg blown off or two legs blown off, just too hard to do.
I don't know. It doesn't seem that hard to me. You could do it with it doesn't, take away the blast injuries, take away the ones that you're talking when they're shredded, because, that doesn't probably have relevance to civilian life. But how about, the ones that get AK-47 injuries? Or, in other words, these are high-energy penetrating traumas. And even if you had to, do the study in 2 different air bases in a year, you'd have at least have a study. At least you'd have something to go by. And if it wasn't going to work in these settings, probably, in these young, healthy people with penetrating trauma, it's probably just not going to work. All right, we're about halfway through. Actually, we're 3/4 of the way through, and we have another 20 to go.
Okay, 11. Rectal exams. Should the digital rectal exam be part of the trauma secondary survey? Basically, these authors kind of go through the literature, and they pulled out all the studies that look at digital rectal exam and trauma and try to summarize what they show. All these studies combine about 3,000 patients, and you know what? The rectal exam is just not that reliable when you look at these papers and you look at the numbers. Poor sensitivity for injury overall and for specific injuries, such as those involving the spinal cord, bowel, urethra, pelvic fracture. it doesn't seem to really add much to your clinical judgment or change your clinical management. You know, a lot of these patients that have those types of injuries, you're going to know that not from the rectal exam, but from some other part of your exam. But this is part of that ATLS mantra that we all get drilled into us, you know, which is tubes and fingers in every orifice, and you roll them, and you got to do the rectal, and you just do it, and you don't really think about whether or not that's adding anything to what you do. And when you really think about it and you look at it, it really doesn't seem to add that much, and we just shouldn't be doing it as a screening tool. It's not a very good screening tool in every single trauma patient that we're seeing. So they do note that the evidence is not great. You can't necessarily, it's not perfect evidence to say don't do it anymore, but it suggests that it really has selective utility, and it probably doesn't add as much as in terms of how much we do it. We do it all the time in every trauma patient, mindlessly. Probably not that much added, not that much value added.
12. So 12 has a couple of interesting things about it. What they say is, if you're alcohol intoxicated, do we do more tests and interventions on you than a similarly injured patient who's not alcohol intoxicated? How many here know that answer without doing the study? Of course we do. When you can't trust the clinical exam, you do tests. And they did a data bank kind of survey, and they said if they had a blood alcohol that was up, they got more interventions. They got more off into the ICU and admitted and endotracheal intubation and in the ICU a day. All those things. Actually, the charges were only like $2,000 more, $10,000 versus $8,000. But so they make the point that we all know that is the case. Now, why did they do this study for something that we all know? They said, well, there's some states allow laws to not cover you if you're intoxicated with alcohol. And they want those states to repeal that. This is trauma surgeons who want to get paid for their stuff. Yeah. Right, so how many have insurance anyway? So the question I had for this was, does anybody know of them actually being denied because they were alcohol intoxicated for if they had insurance? See, at least where I am, this stuff the best thing is that this goes on your automobile insurance, not your health insurance. So the study's true, we all know that, I don't think it's rocket science, but they did it to get people to repeal those laws, so I think that was the purpose of it.
A couple papers on shoulders. Now that you used to have them in a sling like this, now they want you to have them like this, walking around like driving a car, trying to get through doorways with the external rotation, because the whole issue here is trying to limit the recurrence of a dislocation. So this is what is the evidence?
We could summarize 13 and 14 together, probably.
Well, 13 says, yes, you're going to have less recurrences if you do this external rotation immobilization for 3 weeks.
And 14 says no. That's pretty much like, there have been 3 or 4 previous papers, all of which were kind of positive. 14, which is actually the best article, says no, it doesn't really help. Why would that help anyway? I don't know, it always sounds, I don't know if you've seen the pictures of this thing. Some guy has made the device. So you send the guy out like this, okay? You do that in New York City, I think you like it because people give you dimes and stuff like that. Either that or you're considered, you get reported to the moral police or something. But if you want to do it, go ahead. It sounds like nothing to me.
The only funny thing about 14 was they used the Hippocratic technique. Put your foot in the armpit and yank. Ooh, this is something from the Stone Age of medicine here.
Well, this is all about the Bankert lesion, which is defined in paper number 13 there. And MRI tests show that is healed more effectively when you're rotated. And most of these recurrences occur in young people under 30. And so if it happened to an older person, that would make the case even more that, you wouldn't subject them to this.
I thought my understanding is it's really, everybody knows what the Bankert lesion is, but the tear, what happens with the shoulder dislocation is you tear the hell out of the capsule. And you have a tear in the labrum. And the idea is, I can't actually picture it, that if you have the thing like this, that might heal better. I don't know, there's a 42% versus 37% recurrence rate. There wasn't any difference there. Do it if you want.
Okay, 15, elbows. This one kind of asks the question, we got the Ottawa ankle rolls, we got knee rolls, things like that. Could we have the same kind of thing, an exam screening mechanism for elbows to know without an x-ray that someone doesn't or does have a fracture. What about range of motion there? So 15 is from the Naval Medical Center, and this is 113 patients, 5 years or older, so they do have some kids in this one, after acute elbow trauma. And they basically, before the x-rays were obtained, they had them do some range of motion. They had them actively flex, they had them actively extend, they did a little supination, pronation, and they looked for point tenderness. And in fact, what they found was that it was pretty good. Like if somebody could really extend their arm, they probably don't have an elbow fracture. That's what this study shows. The sensitivity and specificity numbers are pretty good. 100% sensitivity for extension, not as good for flexion, only 64%. But point tenderness also seemed to correlate. So, doing a range of motion helped, and it seemed you could probably not do an x-ray in somebody who could really move their elbow around. I don't have any problem with a paper that emphasizes exam, over test. Anything that's going to make our exam a little bit better of any joint. Exam is free, so if I'm going to examine a little bit more and make a decision, I like that. Anything that focuses on exam is good. So, if someone could actively fully extend and they don't have point tenderness, this paper would imply that you don't need to get an x-ray on those people. They don't have an elbow fracture. There you go.
And not just this paper,
but 16 too.
Database alone, we probably have 5 or 6, there's probably 20 in the literature that say that the extension test is almost a perfect test. And even if it wasn't, sometimes maybe you have a little fracture, you would never do anything about it anyway. I mean, having blood in the joint, that's God's way of preventing you from bending it, and moving it around.
Right. So that's actually what 16 shows. This is a British study, and they basically said, if you could fully extend, and you weren't a child and you weren't point tender over the olecranon, it's real good. I think they missed 1.6% of them. And in typical British fashion, they say, well, that's good enough. Of course. Actually, I think what 15 showed was that if they could flex, extend, pronate, and supinate and didn't have any pain, they didn't have a fracture. I thought, well, what'd you get the x-ray for? How did they have an injury with the ability to do all that stuff?
17 says that if you have a knee injury of any consequence, that in terms of the quality of life and cost effectiveness and missed work and the convalescence time, the fastest way to get you better is to try to do an early MRI to see if you have any structural issues there. And that's what happens with doctors. You're not going to get a plain X-ray for your knee. You're all going to get an MRI. But what happens when somebody else comes in? You see these people come in and they got a big swollen knee, and when it's swollen, that's a hemarthrosis. And when it's a hemarthrosis, you can just bet there's some internal derangements. And the study that they need is an MRI. But we do the plain X-ray. You say, well, the plain X-ray looks okay. You put them in this big Velcro immobilizer and say, check in with an orthopedist if you can get an appointment in the next 60 days. When in fact, why don't we just get the MRI right then and there? I mean, we've done that. The machine's there. It's all, why not, kind of thing.
Really?
Really.
It's expensive.
And so what do you do when they have a small cartilage tear? Well, let's just see how it goes. And what do you do if they have an ACL tear? Well, you see how it goes, and you give them rehab therapy for 6 months before you fix it. I mean, I don't see any reason to... I see a reason to sometimes do an MRI to finally get an answer, but I don't know about utilizing the ER to do that.
And the idea is that you finally get an answer. Lots of studies have shown MRI can be quite bad in both directions. So.
Well, you might as well give it to the hospital because the orthopedist is going to order it anyway. So the hospital needs some money.
All right, number 18.
I can't believe all three of you are wrong.
I think you're at that. Aren't you at kind of a fancy little private hospital there, and that's what's going on?
Would you do it in the 70-year-old lady who doesn't really have rehab potential, is not going to be that active? I mean, all comers with a swollen knee? Or are we just talking about, young, active people?
He doesn't mean that. He means people a lot younger than himself. Oh. Number 18, let's see if we can do this in 10 seconds. Okay? Meta-analysis, should you do early imaging of back pain if there's not a red flag? No. That's what it says. Every one of those articles say no, doesn't do you any good. MRI, that doesn't do you any good. X-ray doesn't do any good. Unless there's one of those red flag things, and you should know what those are, like you've had trauma or you're especially young or whatever kind of thing, then the X-rays don't do anything. As we've said here many times before, if you want to radiate these people's gonads, which is what lumbosacral films and CTs do, there is an advantage to that. Rick, what's the advantage of radiating their gonads of this population?
You'll mutate this subset of the population off the planet.
They'll mutate off the planet. They will not be. It won't help you. because they won't be able to breathe, but your children, if they go into emergency medicine, won't have to deal with the problem.
So this is actually a very important paper, I think. In its conclusions, Deo is the other guy who's the author here. He's written every guideline for everything on the low back. And you would think that, well, if they came in and we could get an MRI on them, he's done the study with just MRI, then we'd really know what's going on. The trouble with that is that you take 100 people off the street with no back pain, 70% will have labrum tears, 60% will have bulging discs. 15 or 20% will have herniated discs with no pain at all. So even when you get this study, you have no idea what to do with it unless you've decided, I'm going to operate on them. It's an L5-S1 syndrome, and there's the disc. It's on the proper side at L5-S1, and they're not getting any better. Oh, that helped me. But short of that, these things don't do anything. And I think a lot of the patients think that, well, gee, if you only knew ahead of time what it was, that would be better. Where I see this come in is VIPs get this kind of stuff. Somebody's a big VIP, and they say, oh, they have terrible low back pain, and they call somebody that they know, and without history or physical, order the MRI, and then they go to somebody for follow-up, and they think they've gotten good care. And what it turns out is they haven't. Doesn't matter.
19 also talks about back pain, but more the treatments for back pain. Basically, these authors, they looked at 76 trials that looked at different treatments for back pain. These were all placebo-controlled trials. So they're trying to pull out the ones that really actually had placebo control to see if anything worked. And they looked at a ton of different therapies, everything from muscle relaxants to NSAIDs to manipulation to TENS. They looked at back school, they looked at facet injections, lasers, magnets, everything. And, what's the answer, right? None of this stuff really helps, especially even when you compare it to placebos. Now, interesting, they note in this paper that 5 of the treatments that were recommended in the 2007 guidelines of the American Pain Society, which are antidepressants, manipulative therapy, exercise, acupuncture, behavioral therapies, none of those have been shown to be better than placebo alone. None of them. And that's the part of this paper is that we throw all kinds of stuff at these patients, but this is a self-limited process. There's none of these therapies, when you compare them to placebo, matter because there is no treatment that matters. It's just going to get better on its own. And that's what this paper kind of comes down to. At most, they have a small effect. At most. But virtually nothing.
There was a paper that we did a long, long time ago. Basically, it said in the title, best if left untampered. Means don't mess with it. It'll get better. 95% of them are better within 6 weeks no matter what you do. But sometimes if you're in the industrial world, hey, you sent my friend to a PT, why can't I go to PT? You're cutting corners kind of thing. So they think shake and bake really matters kind of thing for an acute musculoskeletal. So last year we did a talk which basically says, if this is the case, then you don't need to know anything about back injuries except the red flag cases. Those are the only things that you need to know about, because anything else that you do, you believe in muscle relaxants, you believe in this, you believe in that, none of that matters. Yeah, you can give it, fine, give something for pain, but it doesn't matter. But you need to know about red flag back pain.
This is really basically, you got to do something while nature takes its course. So that's why there's so many of these things that are out there, of course. It's going to happen that way. Right. But, when I've had bunch of episodes. In fact, the first time I ever did this course at Whistler, I had terrible low back pain on the last day of it and had to, carry all my stuff back to Michigan. I mean, at that point, you would do anything. You would say, cut open my back, do all that kind of stuff.
Yeah,
and all that stuff
sucks.
just goes away.
Yeah,
right.
It's
awful, but you just got to convince people that it's a pain management issue, not anything else. Yeah. Right, because they express care to the patient. Actually, that's what I think physical therapy is for. It's to let people know it's safe enough to do normal activity. We do industrial medicine stuff, and when I know somebody is scared to death of their back pain, they're not motivated to do anything, I send them to physical therapy because they, in a structured way, have them do and let them know that they can do normal things. 20, I think, is actually a great issue. How many here use oral steroids for acute sciatica?
A lot of hands, actually.
Yeah, so, it has a sort of physiologic plausibility. Okay, there's a herniated disc. it's pressing on the nerve, and there must be an inflammatory response, and so let's give them the big-time anti-inflammatory. To my knowledge, there's never, ever been a study that shows that it works at all, let alone in a controlled fashion. And this one had sort of a funny way of measuring things. And they said maybe they got a little bit better a little bit sooner, but not much. And then no differences between physical activities, medication use, return to work, usual activity. More of those got epidural steroid injection in follow-up than the control group, but you've already now selected people who think that maybe steroids are going to be something. I don't think there's any reason to think that it works, but I know it's a commonly done thing because, again, you want to do something in the face of bad pain.
All steroids aren't a free shot. You have to also remember, in a diabetic person, you gotta, you don't want to necessarily just hand out steroids like candy just because you want to do something, because in some patients this could really hurt them. And so, think about that as well.
It could cause atrial fibrillation. That's right. You don't want that on your conscience.
Yeah, I'm going to take a little different point of view from this. I think what you said about there's no study that shows it works, I think that's just wrong. What it shows is it doesn't change the natural history of the disease like so many other things. It doesn't do that. But we're talking about sciatica now, and that's the problem with these in most papers, is they take people who come in with back pain and they have pain down their leg. Well, steroids don't actually help the back pain. And that's what their pain is, as you know. I mean, it helps sciatica kind of terrifically, most likely, but it doesn't change the overall course. It makes it better. Whatever makes that disc go back in, it's very hard to picture it, or it stops pressing on the nerve. I don't know if you can picture it, but I have trouble with that. Those kinds of things, it probably helps quite a bit early on. So I remember having some thin, healthy residents that had back pain with sciatica, and they literally were able to go to work 3 days after they got steroids. And, since the disease gets better after a couple of weeks, usually, of course, in the long run, it's not going to make a difference. But as that young woman said, that couple of weeks can make a difference to a patient,
Well, 21 is a paper that looks particularly at radicular low back pain. This is sciatica, which is symptoms radiating beyond the knee. And they compared, in this 82-patient randomized trial, long-acting methylprednisolone versus placebo. There was no statistically significant difference, but most of the things that they measured trended in favor of the steroids. So they say you need a larger study. But I think that even if a larger study was done, the question then will be, what would be the number needed to treat to get some benefit? Because in this study of 82 people, half of them got it, half of them didn't. If you had it and it showed no statistical difference, if you need to show a statistical difference, what if you needed 800 people to do this study? Yes, the differences now may be statistically significant, but how many of those people would get benefit? The number needed to treat is implied in this study to be quite large.
Yeah. I don't know. The numbers they have here are things like 47 versus 68%, 46 versus 61%, 22 versus 43%, 14 versus 20. Those are usually an absolute difference of 15 or 20%. I think that's quite a bit. When you have this back pain and this leg pain, if you had a 1 chance in 5 of getting better by taking this one shot, I'd take it.
The problem, though, is that because it's not statistically significant, you could find a trend just going the other way just as easily.
No, you could find it, but not just as easily. Right.
A little harder. Where are we? 22.
22. We still in business here? Yeah. One more. Okay.
No, 6:30.
Yeah.
Oh, great. Yeah.
You're leaving at 6, but we're staying till 6:30.
This is actually kind of a complicated article, number 22, and it doesn't say what it seems to say, which looks like it's a comparison between paramedic-performed pediatric intubation in the field and doctor-performed intubation in the field. It's a European study. So if you just sort of look at the outcome of it, it looks like the doctors did, this in kids, the doctors did incredibly better. The mortality rate, survival was much lower in children intubated by paramedics. That's 5% for the docs versus 69% for the paramedics. And that just sounds amazing. How could it be that much of a difference? I think as maybe everyone doesn't know, the issue of whether you should intubate kids in the field is a real contentious issue anyway. One of the best studies in the database was done by, Gaucher in Los Angeles, a true randomized prospective controlled study of pediatric intubation versus non-intubation, and the intubated kids did worse. I mean, it was better to not intubate them, breathe for them, and bring them to the hospital. So, at any rate, this isn't unfortunately like that exactly. This is about kids that are very severely injured in the field, and they call what they call the HMT, the helicopter transport. And the medics who were on the scene had the option of either doing standard care, which meant first bag valve mask, until the doc got there. In a lot of European places, the docs are either on ambulances or helicopters, and that's an anesthetist, what we call an anesthesiologist, and then he or she would intubate, or they could go ahead and intubate. So there's a subtle difference here, sort of like the things Neal was talking about. That's not the same group, because when the medics decided, if you read it carefully, that group where the medic decided to intubate before the doc was there, those kids were in cardiac arrest. That's why only 5% survived. In the group where they were having some respiratory insufficiency and they could bag them, of course they weren't in cardiac arrest, and of course they did much better. So I would have loved to see this as a randomized trial. Who knows what would have happened there? But in this case, it's nothing like that. It's sort of like saying that if you're in cardiac arrest, meaning you're dead pretty much, that you're going to do a lot worse than if you're not dead.
But this paper also says that more than a third of the kids that were intubated by one of the paramedics required emergency correction of the tracheal tube placement.
Okay, let's look at that phrase. Required. What does that mean? Required. And who's judging this? The anesthesiologist. So in other words, the anesthesiologist looked at the medic's intubation, probably could find nothing wrong with it. They didn't say it was, in the esophagus. Oh, I think it's down the right mainstem bronchus. Something, I think I better take a look. And they said, yes, they did something about it. I mean, what does that mean, requiring? I'd like to know, actually.
Aren't you in a argumentative little mood today, Doctor?
Actually not. I just happened to get to all these articles that are, those are, 5 versus 90.
They did this study in Orlando where they looked at the intubations by the paramedics, and they came up with some really distressing number of intubations that were in the wrong hole and this, that, and the other thing.
And that's not even kids. That was adults.
That was adults. The number was something like in the neighborhood of 20% or thereabouts.
That's even worse than that. That was at autopsy. That was by the coroner. So even after you had time to see that you screwed up and put it in the esophagus, and take it out and put it back in again, it still was that bad. So absolutely, I'm sure people are capable of doing, making mistakes, but this doesn't actually tell you that.
I think that this just reaffirms the Marianne Gaucher study, which is that, good bag valve mask in kids until they get to the hospital is probably just fine. And that, if you don't intubate kids a lot and you lose your skill, you might put it in the wrong place, and in a kid that would be a terrible thing. So, you should bag kids until they get to the hospital. Now, if you're in a place of system where the EMS transport time is a long transport time, that might be a little bit different argument. But if you're in an urban place where they can get to the hospital, bag them. Bag them.
Yeah, I agree, but I can't help it but say this. That if you look at that thing about requiring tracheal tube placement, it's requiring either tracheal tube messing around with or changing a ventilator setting. Okay? Has there ever been a ventilator setting in the world that hasn't been changed by an anesthesiologist or respiratory therapist? None that I've ever done.
All right, 23 is actually a paper that's in the COPD chapter, so I think we should skip it.
All right, skip it.
Yeah.
All right, 24. How many here have a alternative airway technique that involves something fiber optic and that kind of thing?
Wow.
Almost everybody
does. Most people do. So this sheds a little bit of light on things, I think, mainly in the conclusions about what these people would do. These are a bunch of Swiss anesthesia providers. So these are people very, very skilled in managing the airway. They've been using the Macintosh blade forever and ever. And so they use this mannequin that can simulate airway obstruction. And then they gave them a variety of other devices to try to see how well they did with getting around this obstruction. And then they did rankings on all these things and failure rates. I think the thing that most came out of it, even though they didn't sometimes get it in with these devices, is that 100% of these providers said, I want one of these things at the end of it. So no matter what the numbers are. And so the number one that came out was the AirTrach and the McGrath device. And actually, the GlideScope was only 3% of them said that they would use the GlideScope. And I think that's a very popular one. How many here have a GlideScope? Yeah, that hit big time. So I don't know. This is anesthesia providers doing it who do this for a living. So I think the only bottom line that's worthwhile taking home is that people who do it for a living want a good alternative to it, and that's about it.
Well, 25 is about people who don't do it for a living. This is 20 individuals with no experience with intubation were taught on a mannequin how to do intubation using a standard laryngoscope with a Mac blade and also using the glide scope, which is this laryngoscope. It's got a TV screen on the side there since most of you own one already. Mannequin training was considered to be complete if the folks could do 3 consecutive intubations within a time frame of 60 seconds each using both techniques. Then they had them do it on 5 real people. The rate of successful intubation in these 20 people who never did an intubation in their lives.
So can't you tell this is not a U.S. study? People who've never intubated somebody before, try it 5 times on a mannequin, and you will like it when we do it on you in this German study.
The rate of successful intubation within 2 minutes was 93% with the glide scope, 51% with the Mac blade, the old-fashioned technique. Intubations were performed faster with the glide scope. Post-intubation throat stings were less frequent with the glide scope. And there was no money from the manufacturer. And what I think what this gives us the option to do is to teach respiratory therapists in hospitals how to do intubations, because in my hospital, the ER doctor is the only doctor in the building from about 4 or 5 o'clock in the afternoon till 7 o'clock the next morning. And when you get called for a code up on the floor or something like that, or somebody's having some respiratory distress, it would be absolutely great if the RT could intubate these people if you couldn't get there. And this says we can train a monkey to do this with this machine here.
Yeah, these things are great. They give you that extra degree, that extra angle of visualization when you get in there that you can kind of see around and see up a little bit. Just that little bit sometimes makes a huge difference in airways that really scared you when you first looked in. And they're great tools. And I like the McGrath one. The McGrath one is the one made by LMA, which is the independent unit. It doesn't have the separate TV screen. It has the little screen on top of a Mac blade, basically. It's got a AA battery in it. And the only problem with that device is that it's just easy to steal for people to come down and take it, because they can just, it doesn't have like an attached screen. You can just put it in your pocket and walk away. But it's a pretty cool device.
How many of you have that one?
The McGrath.
With the screen on the end of the blade?
Yeah.
Do you have both or just the...
Yeah.
And what do you think?
Yeah.
In the back? Somebody else had just the
McGrath.
So the glide scope, basically, the sales force and that, they just got cornered in the market.
Yeah, no, GlideScope's amazing. They have marketed their product quite well because they really have penetrated. Look at all these departments. They've really penetrated the departments.
Although one of our other faculty said there's something very similar to the glide scope made by a different company, which he evaluated and which he thinks he prefers. I don't know what it. I
think we have a comparison of 5 of them somewhere in the literature, and the GlideScope didn't come out very well on that. Yeah. I don't know about this McGrath, this thing with the little. Why do they steal it? Do they bring it home and use it in the bedroom?
No, but
what do you do with
the anesthesiologist upstairs? Not that they come.
The anesthesiologist do it in the bedroom.
Yeah.
Oh, why can't you tell me those perverts?
I think he's a little under-medicated today.
All righty, number 26. This is a little bit interesting. This is the rocuronium versus the succinylcholine thing. I'm sure most of you are very comfortable and know all about sucks, and that's what we use since it's so short-acting. Well, rock is a pretty short-acting drug too, and of course it could avoid some of those sort of relative contraindications of succinylcholine, and it was touted as being very rapid onset, and you could really compare the two. And there's a number of articles, and I think people have used it, kind of said it's actually not that fast. Sucks is still better. Well, it turns out with sucks, with rock, that you have this stuff, and I was pronounced wrong, Sugamadex, thank you, which reverses it. And remember, you can't reverse sucks. So the company, Schering-Plough, who had obviously had all this data, and they knew how this was going to come out, they went out and funded this study in a few different centers, with a decent number of patients, over 100 patients, to look at the time that it took for people to recover after either getting sucks at 1 milligram per kilogram or rock, slightly relatively lower dose, 1.2, followed by the reversal agent. And it came out, I'm sure the way they knew it would, which is that when you gave rock with the reversal agent, at least by the standard they used, it was faster. It was maybe the difference between 10 minutes and 6 minutes. And they judged, the thing you could argue with, I know Jerry argued with on the tape, was that they used this twitch index. when the person starts to twitch, which I don't know much about, and there's a 10% and a 90%, and who knows exactly how relevant that is. Does that mean they can breathe, for example, which would be pretty relevant? But you would think, since both the 10% and the 90% were better after you give the reversal agent, that it might or might not mean something. It certainly seems to me, if you are going to be using this agent, the rocuronium that is, that it makes perfect sense to have this available. And if somebody has experience with it, I'd love to hear it.
Well, we should ask the radiologist, the anesthesiologist down the hallway there.
Is this stuff available in the U.S.?
No, it's still
Right.
right. Well, so
Yeah, but
Sugamidex is
isn't
not available because there were allergic reactions, and so the FDA took it off the market. But it's still being used in Europe and other. Well, because the neurosurgeon wants to wake him up and examine him.
No, I think it's if you don't get him intubated.
Yeah, this is when you haven't got the airway.
That's the idea. If it's a failed airway, rather than cutting on their neck, you could squirt them.
Get a glide scope. Yeah, get the glide scope.
Yeah, but if it were true that you could really reverse your paralytic agent and Sugamidex, those who use it in Europe and talk about it, they think it's amazing. I mean, you can basically reverse your paralytic agent. That's pretty amazing if we get Sugamidex back.
Do any of you Australians have this stuff?
They never miss an intubation. That's what I've heard.
That's right.
What I like about the study is there was one serious adverse event. Did you see that? A pelvic hematoma. I don't know what's going on. I don't know when people are getting paralyzed. Yeah, it's not right.
27, sedation after intubation using etomidate and a long-acting neuromuscular blocker. This is a horrific paper that talks basically about the phenomenon of people getting paralyzed and getting etomidate, and then we leave them naked for sedation, right? They get paralyzed, the etomidate wears off, and they're paralyzed, and we don't do anything about it. We don't give them anything. And the etomidate's very short-acting, and they're paralyzed, and they can't speak up, and all you look over is you see them, their heart rate, they're going 140, and they got a tear coming down, and they can't do anything about it. This is a chart review in 84 patients in a PEDS ER in Alabama. They got etomidate, they got either ROC or VEC, and then they basically looked at when did these people get an additional sedative, if at all, and some of these kids got nothing. These kids were about a mean age of 7 years old. More than 90% of them had gotten ROC with etomidate. Of the patients who received etomidate, 13% of them got nothing, no additional sedative whatsoever. About a quarter of the patients got a sedative within 15 minutes after the etomidate, while 65% of them got a sedative more than 15 minutes after having been given the etomidate. And the mean time from the etomidate to an additional sedative was 46 minutes. I mean, it's just horrific. And the kids with the lower GCS scores, 3 to 8, got even more delayed to their sedation. And it's just really awful. And it just, it's typical though. The typical scene is that, you paralyze somebody and you intubate them. Everyone's, doing their high fives, and it takes a while for you to order that additional medication. And it just argues for, get the Versed drip or the propofol drip or whatever you use for your intubation sedation, get that up and running as part of your intubation setup. Don't wait until later to think about ordering those medications, which is often a typical way of doing it.
There was a paper last year that basically said the same thing occurred in adults, and these people were just paralyzed, and it was a huge percentage of patients who got neither analgesia nor sedation. Yeah. Neither.
It's just
So
crazy.
I'm not very much for all these protocol-driven things that work in one part of the hospital, trying them elsewhere, so that we have to mark, do the timeout when you're going to intubate somebody in the ER, so you don't put it in the left trachea, or you don't intubate a sprained ankle or something like that, or do a lumbar puncture in their other spine, or I don't know why we would do that kind of stuff. But this is something unique to the ER that should be protocol-driven. You should have, it shouldn't be a one-drug kind of thing. It should be, you give etomidate, and then the nurse just says, okay, just write etomidate per protocol. There's the dose, and then the next drug is something that's a sedative at X amount of time, and you can forget about it. Because I think intubation is probably the biggest skill an emergency physician has, and it's the most, you're rolling all the marbles on that child or an adult's brain very quickly, and the instant that you get it in, thank God. Oh, my God, now we're okay. And then you do other stuff. I mean, it's just natural that everybody forgets it. So I think that's why protocol should be enforced.
Yeah, I don't think I disagree with that, but maybe I'm missing something here. I mean, the people who had it delayed had a GCS of 3 to 8. Obviously, aren't we going to be I mean, etomidate is not going to be your big concern if you have a GCS of 3, right? Or 4 or 5. You're not conscious. You're not feeling pain. Right?
Unless it's
Wrong?
now changed. Unless
I mean,
it's now
I don't
changed.
know what the percentage is. What if it turns out that most of these patients were dead? That's a GCS of 3, pretty much. You know?
Right, they had an airway obstruction. That's why they weren't moving. I don't know.
No, GCS of 3 means you're dead. I mean, we don't know how many, 4, 5, 6, 7. And these people are comatose. That's why we have that criteria for intubating people with a GCS of less than 9.
Right, but they had GCSs of 9 to 15, and even your GCS is close to 15.
Yeah.
And that was delayed 27 minutes.
Yeah, but that is... that's fine, but I'm saying the real delays were in the patients who are the least likely to be conscious. And I think that's not the craziest thing wrong. Yeah.
28. This is one of those, of course, kind of studies. So if everybody's given out Bactrim for urinary tract infections, what's going to happen to the E. coli? They're going to get resistant to the Bactrim. So what they showed is that happened. And then so they said, okay, there's a lot of E. coli resistant to Bactrim. Let's switch to a fluoroquinolone. Well, what's going to happen to the germs? They're going to learn to be resistant to fluoroquinolone. And that's basically what it shows, that the Bactrim prescriptions went down, the other prescriptions went up, and the resistance went up. But however, in this case, which hasn't happened in others, the resistance to the Bactrim didn't go away. In a lot of other studies that we've looked at, when you stop using the one drug, you get the resistance from the previous one goes away. I think part of it is that there's many sources of getting the Bactrim in the community other than just this little study of urinary tract infections, and it's given in animals, and so I don't think that's not a foregone conclusion here.
29 looked at. Is that right? Yeah. 29 looked at cultures for E. coli, 10,000 of them, and sensitivities over a 4-year period, and found that. Let's see. The resistance to Cipro and Levaquin went from 20% to 25%. Bactrim went from 26 to 29%. And nitrofurantoin, 1% to 3%. So they said this old friend needs to be brought back into our armamentarium of things that we use for urine infections because it's cheap. It costs $1 compared to Levaquin, which costs $12, and Cipro and those others, which are also more expensive. Bactrim is also cheap, but the resistance levels to Bactrim are substantially higher. So this would suggest that this would be a good drug to start using again.
Sounds okay to me. I mean, first of all, I think I have a problem. If the best old friend you have is furidantin, you got to get out more, I think. That's kind of bad. I mean, I think for you it was probenecin and penicillin, so I'm glad that's coming back. That's all fine. I don't know, as long as we have a second. Let me point out that the resistance things to Bactrim, there's so many things wrong with thinking the gold standard is what the disc says. First of all, it's always been lousy with sulfa drugs. It doesn't mean anything. Second of all, the disc they use is much, much too small because these are concentrated in the urine. So with things like penicillins and most of these sulfa drugs, there's 1,000 times higher concentration than in that 25 microgram disc. And so clinically, this does not in any way mean that of the outpatient sort of infections that you see in young women, that anything like 25% will be clinically resistant. It just doesn't have that kind of meaning.
The other thing just to note about macrobid is that, or nitrofurantoin, is that it's concentrated in the urine, but it has terrible systemic penetration. So if you have any suspicion of a pylo component, don't use it. It's got terrible, outside of just concentrating in the bladder and treating a true cystitis, it's just a terrible drug for anything besides that.
It is especially good in pregnancy, though, as a nice alternative. A little bit of nausea, but it's funny how fast you run out of drugs in pregnancy when they're allergic to penicillins, right? Because you can't give the quinolones and you really run out pretty fast. And then finally, I'm glad I got to do number 30 because I won't disappoint you. No, this is the nuttiest. I mean, this, ever so often, you come across a paper that is obviously ridiculous. The results could not possibly be like this. And when you do that, about 25, 30% of the time, I'll have to do the study, they come from Turkey. And they often have lots of patients, and the results are usually, incredible p-values. And anyway, here's what they did. They wanted to see if maybe they could kill 2 birds with 1 stone. I think that sounds better in Turkish, actually. And so they used the state-of-the-art drug Benadryl on people that had
No, that's not Benadryl. That's
diphenhydramine. It's almost this.
It's Dramamine.
It's right, and that and meclizine. Those three drugs are chemically almost identical, right? One is diphenhydramine, one is diphenhydramate, and anyway, Dramamine. That's a great drug. So you think anyway? They give the shot, and guess what happens? Not only does the nausea go away, but the pain goes down, but not just by a little bit, but by an unbelievable amount. From a pain score of 90, 79, or 81, or something like that, it goes down in 20 minutes to numbers like 27 and 19 in the one group, and doesn't go down at all in the other group. I mean...
So what's the problem here?
What's the problem, right? Benadryl was that, I mean, that's better, than you can do with morphine and, and Toradol and Compazine together. So I just think this doesn't have
Too
any
good to be
validity
true.
at all.
Too good to be true.
The other thing was that, can you imagine getting this study done here? So we know you have the worst pain in the world. You have renal colic. What we're going to do is we're going to wait 30 minutes. And then we're going to measure that in the first 30
This is
minutes.
Turkey.
I know, it's
They
unbelievable.
had the German guys come over from the Mengele.
Yeah, you got terrible pain. We're going to give you a saline placebo. Here you go. Good luck with that.
There's a Canadian physician who works at our hospital, and I don't know whether this is a universal problem, but he loves Dramamine. I mean, he gives Dramamine for everything. I think that are you Canadians into this drug, Dramamine? Yeah, you are.
That's a Canadian drug.
I'll bet it increases your QT interval or something like that. It'll have a black box if we try to use it, so lay off.